Good afternoon. I've been tasked today, and I appreciate the opportunity to talk to you a little bit about trying to put some of this research into a clinical context. And I appreciate Dr. Kaplan's talk. I now think we have a lot more things we need to try to target. But I wanted to talk a little bit about, I think, as I come as a clinical researcher to hear some of the basic science that's going on and a lot of research that has made really tremendous progress in our understanding of the biology of pediatric brain tumors. I still, when I meet a new patient, I'm challenged by often recognizing how far we still have to go in terms of translating some of these things into actual clinical benefit for our patients. And so when I, as a fellow, decided that I wanted to kind of enter into the field of developmental therapeutics, and I think a lot of people start a clinical fellowship thinking along those lines, I think that comes from really thinking about our goal in taking care of children with cancer is really to continue to improve their outcomes. So we've made progress just in cancer in general, and this is not pediatric specific, but the outcomes for patients with cancers in general have improved somewhat over time. Unfortunately, those have improved differently in different areas, and particularly as a neuro-oncologist, pediatric brain cancers remain the leading cause of death due to cancer in children. And so we still have a lot of work to do. And while we have some wonderful successes, and I'll talk a little bit about some of those, there's still obviously a lot of work to do. And so I think you've heard some different ways that we, have tried to think about kind of, that ideal of finding really the right targets. And that may not be a single target, it may be multiple targets. And I think that's part of the complexity. And I think now we have to think about those targets both in the tumor and the microenvironment and all of those things. And so that obviously is a complex task. But we can talk a little bit about and hopefully learning from some of the successes that we've had in treating some of those maybe targetable mutations that we've found and have become more aware of in cancers. And so, we've integrated targeted therapies into pediatric cancer therapy for a number of years, although it's still relatively new. We think about most of our treatments, the primary backbone of those is really in very broad cytotoxic agents, and the integration of targeted therapies is somewhat newer. And this just was one of the earlier examples in ALL of using imatinib in patients with Philadelphia-positive ALL, and you can see there was some tremendous improvement in the outcome of those patients. And that's really transformed the therapy of the treatment for patients with what was historically a very high-risk disease. And hopefully with continued understanding of the biology, we will continue to make advances in all of the cancers that we treat that are similar to this. And so when we think about integrating targeted therapies into our treatments, I think it's a challenging task. And so we have to think about, do we have the right target? And as cancer has gotten more and more complex, and I'll talk about examples of this in a few minutes, we now have not just single diseases, which we used to define by the histopathology, but multiple subgroups of those, and often those subgroups are characterized by differences in mutations and things like that. We've heard about the tumor heterogeneity and the microenvironment perhaps heterogeneity, and that adds additional challenges in terms of subsets of tumor cells, which we may be able to successfully target one subset, but not other subsets. And then, thinking about the target that we identify, they may be present, but may not actually be the driver of the disease. And then additionally, when we think about moving these into the clinic, we may have wonderful preclinical evaluations or wonderful science that helps guide us to what we think is the right target. And when you knock down that target with various ways in the lab, that may be extremely effective. But whether we can get a drug into the clinic and into a pediatric patient that targets that particular alteration, and whether we can get that then further in brain tumors into the brain adds additional challenges. And so sometimes we think we have really good targets, and we're still tasked with the challenge of kind of getting drugs that can target those effectively. And then even if we are able to target those effectively, and there's some examples more recently of difficult to treat diseases where we've had some really exciting successes, but often those successes with targeted therapies are not durable, especially in a more malignant situation. And so understanding the mechanisms of resistance hopefully will help guide us to kind of the next steps in targeted therapy. And then kind of further along those lines of getting the drug to the target, are there different ways that we can think about being creative in terms of getting drugs into the tumors? We think about this a lot in the brain because of that additional barrier of the blood-brain barrier. And thinking about novel drug preparations, liposomal preparations, nanoparticles, different delivery platforms in the brain. There's been more direct delivery and sometimes in other solid tumors as well. So these are all things that we continue to think about as we translate research into the clinic. And so thinking about some examples, and that was the goal, was to kind of give a few examples of some situations that where we've been using targeted therapies in the clinic in children with brain tumors. And one, this is just a kind of prequel to a discussion about some of the early successes. So, we sometimes have gotten clues to thinking about some of these targets in terms of rare diseases, where we've identified and had longer-term understanding of some of the genetic deficits that may underlie those diseases. And so tuberous sclerosis is really one of the early examples of the success of a more targeted therapy for a brain tumor. And it's honestly one of the, unfortunately, rare examples of a drug that actually has an FDA indication for treating a pediatric brain tumor. And so in tuberous sclerosis, you see defects in TSC1 and 2, which acts to inhibit mTOR, acts as a complex to inhibit mTOR. And so the long ago, or no, actually not that long ago, but kind of earlier in our experience of thinking about targeted agents, these were treated by surgery only, but sometimes these weren't surgically resectable tumors. And so an early trial in 2010 looked at a small number of patients that had what were considered to be unresectable tumors, and treated them with an mTOR inhibitor, everolimus. Everolimus was in a class of agents that was actually originally developed more to be immunosuppressive, not thought to be anti-cancer agents, but has actually been utilized in a number of different settings due to its effects on the mTOR and the mTOR pathway. And those patients demonstrated marked reductions in their tumor volumes as well as seizure frequencies. And so subsequent studies of this agent in a larger patient populations of tuberous sclerosis subsequently led to the FDA indication in both pediatric and adult patients for that disease. And this is just an example of a patient with a subependymal giant cell astrocytoma in a patient with tuberous sclerosis that responded to mTOR inhibition. You can see, the tumor kind of prior and just after several months of therapy. And then, so as we kind of started to see some successes with targeted therapies getting into the brain, and I will kind of say one caveat is that one of the challenges in thinking about these treatments in brain tumors is also the fact that as companies and different individuals and organizations that are developing targeted therapies, oftentimes are actually trying to avoid drugs that get into the brain because those can sometimes be fraught with neurologic toxicity and more challenging toxicities. And so that does add another layer of challenge in terms of thinking about moving or availability for drugs for treating the children that we care for. And so for those of you that aren't familiar with brain tumors, low-grade gliomas are actually the most common brain tumor in children. If those can be completely resected, then that's generally curative. Unfortunately, though, many of these occur in the midline structures of the brain and are unresectable. And because of these tumors kind of lying in locations very close to very critical parts of the brain, our goal is to, of course, avoid surgery or things that would lead to more deficits. And so over time, and historically and in adults, radiation therapy is often utilized and can also lead to some long-term cure or at least long-term stability of disease. However, these often occur in very, very young children, and radiation can really be quite damaging neurocognitively, can lead to significant delays into its own neurologic deficits. And so chemotherapy was started as a mechanism to avoid radiation or to delay radiation. However, patients often will progress after completions of chemotherapy, although they may respond initially, and they often require treatment on and off throughout their childhood. And you can imagine that this may significantly impact their life. Families that are coming to clinics to see us weekly for a year-long treatment, and then again a year later, a few years later, for a similar treatment regimen. And for a long time, we didn't know a lot about kind of what drove the biology for most of the patients with low-grade gliomas, although we had some clues potentially from the fact that patients with neurofibromatosis type 1 who have mutations in the NF1 gene, which had long been described to cause activations in the MAP kinase pathway, actually also have a high frequency of low-grade gliomas. And so eventually, as we got as people started to look at these kind of rarer tumors with larger genomic subsets and things, it was identified that a majority of patients with pediatric low-grade gliomas have a fusion in the BRAF gene, which also leads to activation of the MAP kinase pathway. And luckily for us, there's also MAP pathway activation and BRAF mutations in a variety of other adult cancers, and so agents that were developing this or that target this pathway had already been in development for other cancers. And this just shows, again, the pathway as well as some of the earlier mutations that were identified. In addition to the BRAF fusion, other mutations in this pathway were identified in smaller subsets of patients with low-grade gliomas. And again, kind of that the types of mutations that we find in these tumors has become broader and broader, but again, the ultimate activation of the pathway for the majority of them is the same. And so based on that new knowledge, there was a phase 1 trial of an agent, selumetinib, which at this point remains as of yet not FDA approved, although I think many in this room have been working hard to change that with an FDA indication, hopefully, for children with neurofibromatosis. But there was, because of this now new understanding of the pathway activation in patients with low-grade glioma, there was testing in a pediatric preclinical testing program which demonstrated regression in a low-grade glioma model. And then again, there was demonstrated responses in adult patients with melanoma with similar or different mutations in the BRAF pathway. And so this was taken in a phase 1 setting into patients with very refractory low-grade gliomas, initially in patients that had already really had their tumors progress after all the known therapies, including often multiple chemotherapies and as well as radiation, which is really what we're trying to avoid. And amazingly, we saw, and this is an example, although I think we have, as we've had more experience, even better examples of kind of a decrease in the tumor over time with these therapies. And again, this is in very refractory patients. So this was extremely exciting results in terms of the potential to really have an impact on these patients. And so that study was rapidly amended to include patients prior to radiation, to include younger patients, and we continued to see very exciting responses, again, in initially very refractory patients. And over the last few years, that these agents have really expanded in their availability and have really begun to transform the way we care for children with low-grade gliomas. They've really become the second line and soon to be evaluated as the first line treatment for children with low-grade gliomas that can't be resected. And there's a variety of different trials that are ongoing. I just list those kind of briefly here. I won't go into the details of that. And this is a waterfall plot from a recently published results of one of the earlier phase 2 studies of selumetinib, which was the first MEK inhibitor to be tested in patients with low-grade glioma. And you can see that there were a number of patients that met the criteria for a 50% reduction or a partial response. But by far the majority of patients had responses which were clinically significant significant. And these are often very large tumors. So even a small decrease in the actual measurements of the tumor may lead to a really critical improvement in the function for the child. And so this and the results of the ongoing studies is really transforming the way that we care for these children. And we'll be moving into trials to be compared about what is our standard treatment for children with low-grade glioma and the more traditional chemotherapy, and I think likely will become the new standard of care. And as someone who has done clinical trials since the beginning of my fellowship, this is really a tremendously exciting change. There are very few things that can really, change our care for this broad of a patient population. So I think it's really exciting, and hopefully is a model in a less complex system for what we may be able to achieve in the future with more malignant tumors. But as we think about shifting our bar in children, we do have to continue to monitor for the long-term effects from these therapies and make sure that we're not missing things as we shift the way that we care for them. And so what about inhibiting that same pathway in high-grade gliomas? Is this a pathway that's also activated across the spectrum of malignancy? Just to put into context, pediatric high-grade gliomas, which includes also diffuse intrinsic pontine glioma, which is really the most difficult tumor that we face in pediatric oncology. And for that treatment, we really can't avoid radiation to date, but often radiation really only provides temporary benefits. And years and hundreds of agents have been tested in addition to radiation, and unfortunately really have not significantly improved our outcome for taking care of these children. But we have excitingly had tremendous advancement in the last 10 years or so in terms of what we understand about the biology of these tumors, and hopefully as we've had advances in other understanding of biology, that will in the near future lead to true advances in our clinical care and our targets. So there are less commonly mutations in that same BRAF pathway, specifically V600E mutations that occur in BRAF in patients with high-grade glioma. And while they're seen less commonly than we see these alterations in low-grade gliomas, they are present and they are enriched in certain subgroups of patients with high-grade gliomas. And again, when those mutations are present, there are examples of patients that have responded to clinical therapy with these types of inhibitors. And so this is exciting for these patients, and hopefully again will lead to some changes for at least some smaller groups of patients. And so there are ongoing studies that are evaluating the efficacy of targeting these mutations also in patients with higher grade gliomas. And as we have heard a little bit about, often in high-grade gliomas, we may come more quickly to resistance, or tumors may be less responsive. And so combination therapies have been of benefit in other malignant diseases with similar mutations, and so are also being tested either with other inhibitors of that same pathway or with immune therapies and things like that. So still building on the small successes in that disease. Just, when we think about kind of these single mutations, we do identify small subsets of patients that have mutations in other targetable pathways. There are some recurrent MET fusion genes identified in pediatric glioblastoma, and it does appear as we look at the landscape for mutations that we see in pediatric cancers that these fusion genes often lead to more targetable and more clinically responsive tumors. And so, again, when we see kind of those rare patients that respond within often a clinical trial that was not specific for particular mutation, that drives additional interest in developing these further. And this is just an example of a patient that actually had a very nice response of one area of tumor to MET inhibition, but unfortunately did have other areas of tumor that were less responsive. And so again, that heterogeneity that we struggle with in patients and tumors that may be more complex than the low-grade gliomas. So we continue to try to really move the bar for taking care of children with pediatric high-grade gliomas. And hopefully further integration of biologic correlates and understanding both what we're targeting and then hopefully even later kind of what the results of targeting that will help us to further understand and be able to better target these more aggressive tumors. And so this is just some examples of some more recent tumors which have really started to try to really critically evaluate the biology of these tumors, and so that hopefully we can understand, hopefully successes, but if not successes, at least better understand some of the failures. In DIPG, one of the challenges, and in pediatric high-grade gliomas, that we for very many years assumed that they were the same as adult high-grade gliomas, and we used therapies that were targeting the same things that we saw in adults. But as we now have moved biology to the forefront of these studies, we've identified that these tumors are very different biologically from the tumors that we see in adults. And so they've been identified to have histone mutations and often epigenetic modifications, and there's been some interesting research that hopefully people saw as they walked along, trying to look at new ways that we can target these changes. And I'll go through these a little quickly, just different types of agents that are being tested currently in the clinical setting that may target some of those recently identified alterations, but whether those will be successful remains to be seen. And so remembering that with these more difficult tumors, we always talk about the bench to the bedside, but remembering that we really have to kind of then take that back to take things to the bedside and then understand where we failed and take things back to the bench again. And this really needs to be a back and forth process. And I'll just skip over that. And then one final example in terms of kind of thinking about subgroups and targeting tumors that, again, remains a challenge but has some rare successes is in medulloblastoma, which is the most common malignant brain tumor in children. Therapy does involve surgery, radiation, chemotherapy, and we do have more successes in curing children and young adults with this disease. However, many of the therapies that we use are fraught with some significant long-term effects, especially in children that have particularly high-risk disease. And so medulloblastoma, when I started residency, was a single disease. It then got broken into 4 subtypes, and it has recently probably gotten broken into many, many more. So where that will finally end will be interesting to see. But we now clearly understand that medulloblastoma is not only medulloblastoma, and that there's biological and clinically different entities. And those occur at different frequencies in different patient populations. And unfortunately, for most of them, we don't understand how to target them, but there's many people working very hard. But there has been some work, at least, in trying to target those patients that have the sonic hedgehog subgroup. That is also fraught with some challenges. But there's obviously a lot of work to be done to kind of target those other larger patient populations. But hopefully we will identify those targets soon. So the hedgehog pathway, there are inhibitors of smoothen, which have been in clinical trials. These mutations also occur in patients with basal cell carcinoma, and there were some exciting responses in patients with widely metastatic disease with basal cell carcinoma, which prompted evaluation of these same agents in patients with medulloblastoma. And there was actually, again, an exceptional response noted in an adult patient with medulloblastoma, which was metastatic, which prompted evaluation of that in a phase 2 trial in both adult and pediatric patients. And there were, again, some responses, although not quite as exciting in terms of the number as we see in low-grade glioma. But again, when we look at the more sonic hedgehog-specific subgroup, we do see responses to that disease. Unfortunately, we now know that some of the mutations that we see, especially in children, really occur kind of further down on the pathway beyond smoothen. So certainly work is being done to try to kind of target that pathway further down stream. So in general, hopefully this just gives you a little bit of an overview of a couple examples of how we're starting to utilize targeted therapies in the clinic in terms of treating children with brain tumor. There's been very clear successes in treating children with low-grade glioma, and in some rare subcases or subsets of children with much more malignant diseases. and hopefully the ongoing and upcoming clinical trials that utilize these approaches and utilize combinations of these therapies based on rational preclinical data will lead to further successes. But we need to continue to learn from these remarkable responders, but think about also understanding those responses and understanding those failures as well in terms of the mechanisms of resistance, either after a response or prior to a response when we might expect one. And then thinking about, we in most cases don't treat cancer with a single agent, and yet we often try study after study of a single targeted agent. And so better understanding how we can combine these agents may really lead to true successes. And then remembering, again, that we really need to have these close collaborations with clinical and more basic scientists and across disease types and things like that. So hopefully we can come up with new ideas and ways to approach these diseases. So building around always our patients, thinking about how to target therapies with the biology and the correlates, and so that we can find them better therapies. And so thank you, as everyone else has added. We would not be here if it were not for trying to find better therapies for the children that we care for, or for all of you that don't care for them. We're grateful for all of the work that you do to try to help us be able to translate these therapies into the clinic. So thank you.